Hello everyone. Today I will narrate another previous topic, pneumothorax. In AIIMS November 15 and 18 and NEET 20, question are asked from pneumothorax. I will explain the question and answer while narrating the topic. I am making this previous year topic guided videos so that you can easily revise the medicine within 1 day or 2. For example, you can revise the rheumatology within 1 hour. You can check the playlist in my channel. So let's start with pneumothorax. It is nothing but accumulation of air in pleural space. Clinical features of spontaneous pneumothorax include dyspnea, uneven chest expansion, increased respiratory rate, chest pain, decreased tactile femmitus, hyperresonance, diminished or absent breath sound, all on the affected side. Apart from the above clinical feature, if the patient have also feature of the obstructive shock, for example hypertension, tachycardia and jugular venous distension, that is called tension pneumothorax, which need immediate needle decompression, chest tube placement, volume replacement, emergency thoracotomy. In NEET 2020, question are asked in a clinical scenario of tension pneumothorax, which is the next best management. Answer is immediate needle decompression in fifth intercostal space, anterior to mid axillary line in case of adults, and second intercostal space in mid clavicular line in case of children. And in AIIMS number 15 and AIIMS 18, question are asked how to differentiate between the tension pneumothorax and cardiac component. These are the repeat question. Answer is breath sound. The Beck's triad, which contains raised JVP, hypotension, muffled heart sound, along with pulsus paradoxus, are seen in both cardiac component and tension pneumothorax, but breath sound is present in cardiac component but absent in tension pneumothorax. So breath sounds are used to differentiate between tension pneumothorax and cardiac component. Spontaneous pneumothorax is two types, primary and secondary. Primary means there is no underlying diseases. Secondary means there is underlying diseases. Primary, this is due to rupture of the apical subpleural bleb of cyst, occurs mostly in tall, thin young male associated with tobacco smoking. And secondary, due to diseased lung or mechanical ventilation with use of high pressure causing barotrauma. Tall thin smoker, COPD. Tall thin ectopyelongitis, Marfan syndrome. Tall thin rubber man, Ehlers-Danlos syndrome. Pediatric Staphylococcus aureus infection in lung, pneumothorax rupture. The spelling is wrong here. This all can cause spontaneous pneumothorax. Secondary spontaneous pneumothorax. In chest X-ray, you can get deep sulcus sign, absent vesicular shadow, pleural reflection. Now coming to the treatment part, it is very important. Pay attention. So spontaneous pneumothorax, first of all, if bilateral or hemodynamically unstable, that means tension pneumothorax, proceed to chest drain immediately. If not, then see the age of the patient and history of smoking or evidence of underlying lung disease on exam or chest X-ray. That means secondary causes. Go to the right side or else left side. No underlying lung disease, that means primary pneumothorax. First you have to look the size and or presence of breathlessness. Size more than 2 cm means at the level of high lung. You should measure the distance between the retracted lung border and the chest wall. If it is more than 2 cm, then it is big pneumothorax. You cannot appreciate here the 2 cm. You should check it on the chest X-ray film itself. So if the patient has more than 2 cm pneumothorax or breathlessness, first we have to aspirate using needle. Aspirate less than 2.5 liter. If success, then go to the planning of discharge. If not successful, then you should plan for chest drain. And at the first, if the size is less than 2 cm and there is no breathlessness, then you can consider discharge and review in OPD within 2 to 4 weeks. In case of secondary pneumothorax, if the patient have more than 2 cm or breathlessness, directly go to chest drain. If the size is 1 to 2 cm, first aspirate. If it is successful, that means the size is now less than 1 cm, then you can admit an high flow oxygen. If not successful, then go to chest drain. And at the first place, if the size is less than 1 cm, then you can admit an high flow oxygen unless suspected oxygen sensitive. and observe for 24 hours. This is the management of the spontaneous pneumothorax. So see you in next video with another PYT topic.